Good morning, everybody. Welcome to Phoenix Children's Grand Rounds. It's great to have you wherever you're joining us from this morning. It's my pleasure to introduce our speaker this morning, Dr. Neil Friedman. Dr. Friedman is a pediatric neurologist at Barrow Neurologic Institute at Phoenix Children's, where he is also the Director for Outcomes, Quality, and Innovations. Dr. Friedman came to Phoenix Children's in 2019 from Cleveland Clinic, where he was the director for the Center for Pediatric Neurosciences. Dr. Friedman received his medical degree from the University of Cape Town in South Africa. He completed a pediatric residency at U of A in Tucson and a pediatric neurology residency at Children's Hospital in Austin. We'll hand it over to Dr. Friedman in just a second, but a couple housekeeping items. We always welcome Q&A at the end of the talk, and you're welcome to put a question into chat, or when we're done at the end of the talk in our Q&A portion, we can have you just unmute yourself and ask a question directly to Dr. Friedman. I think that's all I have, so Dr. Friedman, we'll hand it over to you.
Thanks, Mike, and thank you for the invitation to speak at Pediatric Grand Round this morning. I joined PCH, as you mentioned, just in November of last year, and it's been a wonderful experience to date. I wanted to talk today about current understandings of neurological injury and congenital heart disease, because as I hope to illustrate, this is becoming quite a significant problem and a burden in terms of cost for society. Now, the debate about the importance and independence of the heart and brain relationship is really an ancient one. And I hope today to correct some misconceptions of the past few centuries and really reinforce the fact that the brain really is of some importance. It's interesting to note that the ancient Egyptians, when they used to bury the dead and mummify them, used to embalm the heart as the source of enlightenment, but the brain and other internal organs were all thrown out. Things have changed a little over time, but fortunately this interrelationship between the heart and brain has remained. But I think there's no doubt these days that the brain is really a very important part of this whole equation. No conflicts of interest other than I do believe the brain is important, and I've got no financial disclosures. So I'd like to start with a brief overview. This is probably familiar to most of you, but congenital heart disease is really one of the most common congenital defects that we see in the United States. It accounts for about 1% of all births in a year, and this translates into about 30,000 to 40,000 cases. However, the babies that we're going to talk about today are the ones that really have critical complex congenital heart disease. And it's estimated that about 10 to 15% of all children have this with heart problems. And this is about 6,500 a year. Of that, most of this talk is going to relate to work and studies that have been done on a group of children with transposition of the great arteries and hypoplastic left heart syndrome, which account for about half of all these complex congenital heart disease. And I think it will become clear as we go through the talk why the emphasis is on these two different physiologies in terms of trying to understand the brain injury that results in children with congenital heart disease. The last few decades has seen earlier and earlier repair, and that about a quarter of all cases are now treated within the first year of life, and most of those actually within the first weeks or months of life. And the benefit being less exposure to chronic hypoxia and a need for less palliative surgery, allowing for corrective repair and therefore less need for bypass. So if one looks at mortality from congenital heart disease, it's truly remarkable what has happened over just the space of 5 decades. What you see in these bars on the bottom is the years, and along the side here, you'll see that VSD has always had very good success as far as survival, even going back into the 1970s. And very quickly, transposition and tetralogy of Fallot, the mortality came down. But hypoplastic left heart, which had a near 100% mortality prior to 1970, has now changed to about a 85 to 90% survival. So the work that is being done is nothing short of remarkable. But there are implications of this survival, and the two major implications has to do with age and neurologic morbidity. There are more adults now with congenital heart disease than there are children. And the neurological morbidity is really being shown to be a significant component of these survivors. So this is work that was done in Quebec and Canada. And what it shows us, hopefully people can see the arrow on the screen, but in the 1980s, the average mean age for a patient with congenital heart disease was 11. By the 2000s, that mean age had increased to 17. And by 2010, the mean age of a surviving child with congenital heart disease is now 25. So this is really moving very rapidly to become an adult disease. And from the same authors from Quebec, you can see the incidence of patients that are now surviving into adulthood and even into the geriatric age range. So there's going to be a whole shift of demographics, and many of the adult neurologists and adult cardiologists and cardiothoracic surgeons are really not familiar with many of these congenital problems and don't feel comfortable looking after them. However, neurologic morbidity is really the major extracardiac complication of children with congenital heart disease, and that's really what I want to focus the talk on today. So we know overall that about 20 to 30% of all comers of children with congenital heart disease will have some kind of physical, developmental, cognitive problems. However, this can be risk stratified by the nature of the congenital heart disease. In children that have relatively mild congenital heart disease, neurological outcome is really excellent. On the other hand, with the children that have the more severe critical congenital heart disease, morbidity is seen in well over 50% of these children. And this is a graph that's published very often in these talks by Gail Wernitzky, who showed that in the white bar here is neurological freedom of disease. And if you have mild or moderate disease, most of these cardiac disease, that is, most of these children are going to survive without significant impairment. On the other end of the spectrum, if you have a child with an underlying genetic syndrome as part of their congenital heart disease, the chances of them having no disability is almost zero. And children with severe congenital heart or with palliative neonatal syndromes like single ventricle, again, a significant percentage of them are going to have neurological problems, with a significant percent having fairly severe impairments. And that's what we're going to talk about and look at. The landmark of cardiac surgery is really an interesting one. In the 1950s and early 1960s, most of the surgery was really just palliative surgery. But things started to change with open heart surgery, initially pioneered in the adults, but towards the end of the 1960s, a couple of older patients with tetralogy of Fallot were done with survival. But the real modern era, as it were, of pediatric cardiac surgery was in the 1970s when Sir Brian Barrett-Boys, who was a New Zealand cardiothoracic surgery, after showing successfully in lamb work that you can actually do these surgeries on very, very young infants, in that case lambs, with good results and good survival. And things have moved since that time to doing these surgeries earlier and earlier. And 50 years later, it really hasn't changed very much. But with survival came the problem of trying to reduce the morbidity, and in particular the neurologic morbidity. So in the sort of late 1980s and through the 1990s, a lot of the work and the studies that were done were aimed at trying to prevent the perioperative neurological complications that were thought to occur. Now, the original concept going into the 1980s, into the 1990s, was that you essentially had a child that was essentially a normal child, other than the fact that they had a congenital heart problem. However, you then put them through this rather dramatic surgery, going on to the bypass, stopping the heart in many instances with no blood flow to the brain, with equipment and machines that has tons of artificial materials such as tubing, artificial pumps, and suckers. And that most of the injury and the damage was thought to have been occurring during the time of the surgery. And then at the end of the surgery, you get a child that comes back from the OR with significant hemodynamic instability for the first 24 to 48 hours after surgery. There's often an open chest because of swelling. Very often they will have pace wires or drains, and in some cases the need for either dialysis or even ECMO. And so the insult was thought to occur during this time of surgery, with ongoing insults after the child is back in the ICU. So to try and understand a little bit of why, what the initial approach was to protection, we have to understand just a little bit about cardiopulmonary bypass surgery. And I think it still comes as a shock to many when I do this talk, when I ask, what temperature you think that these children are operated under. Most people think about the neonatal hypothermia cooling, which is at 32 to 33 degrees. But in fact, under bypass, the babies are cooled down to about 18 to 22 degrees, depending on the type of surgery. And this isn't a random number. The reason for this is that at that sort of temperature, about 2/3 of children will have an isoelectric EEG. That is a flatline EEG. But even at that sort of temperature, the basal metabolic rate of the brain is still about 10%. So there is a requirement and a need for energy and for nutrients. However, given the reduction in this need, you can safely operate for a period of time without resulting in significant brain injury. In the very earliest days, they actually were operating in temperatures down to about 10 degrees, but the morbidity and the mortality from those low temperatures were quite dramatic. And at the start of the surgery, it's just cooling the body, packing the head with ice, cooling the operating room. But in order to really get these temperatures down to the 18 to 20 degrees, they have to go onto the bypass machine to allow that blood to be cooled. And this is really the critical period. At some point, the aorta is clamped, and again, in total hypothermic circulatory arrest, there'll be no flow to the brain. Increasingly, over the decades, surgery is being done with low-flow bypass. We'll address some of that a little bit later. And then following the surgery, the babies are warmed up. But studies have shown when you look at use of the infrareds and look at mitochondrial function, that the mitochondrial activity often takes about 24 to 48 hours to fully recover. And hypothermia itself has some significant adverse effects, probably the most significant of which is when you get down to these temperatures, the child becomes, the child loses the ability to auto-regulate. And as such, they have what's known as a pressure-passive curve. And so for every change in the mean arterial blood pressure, it gets immediately and directly translated into a pressure in the brain. So when the blood pressures go up at this end of the curve, the pressures in the brain go up and you run the significant risk of bleeding. At the other end of the spectrum, when pressures start to drop, the blood flow into the brain drops and you run the risk of ischemia. On bypass, you also lose pulsatility of blood flow. You don't have the systolic diastolic flow. And for reasons that are not entirely clear, neurons seem to like this pressure gradient between the systolic diastolic pressure, and that has been shown to be a significant problem. At these temperatures, there's increased blood viscosity, and there's also an increased oxyhemoglobin affinity with a reduced release of oxygen. And one of the things that is quite dramatic, and there have been some incredible studies looking at this, and some of the early protective studies were aimed at this, is almost the minute the child goes onto bypass, you get an incredible inflammatory response with a breakdown in the blood-brain barrier. And that's why a lot of the surgeries are done looking at using steroids and others to try and dampen this inflammatory response. And then at the end of the day, the child comes back from the operating room, is often kept paralyzed for the first 24 to 48 hours. Significant arrhythmias may occur, and there's a lot of hemodynamic instability. So if we focus a little now on the neurological morbidity associated with the congenital heart disease, there really are three major neurological concerns. Two of them occur early, and I'm really not going to talk about that today. Those are strokes, seizures, and epilepsy, which is obviously a more long-term complication. I'm just going to touch on a couple of key components, but really want to focus on the long-term effects of bypass, of congenital heart disease that was thought to be due to the bypass surgery, and that is the neurodevelopmental disabilities. So if we look at stroke to begin with, the incidence of stroke, most of the work has been looked at is following the Fontan surgery in particular, with incidence rates of about 3 to 20%. What's to note here is that the lower incident rates were all based on clinical studies of stroke, in other words, clinical detection of stroke. And that can be incredibly hard in a newborn, especially when they kept paralyzed or heavily sedated for days after surgery. Whereas the higher numbers are based on MRI imaging evidence of stroke following surgery. Gabriel DeVega's group up at Sick Kids in Toronto looked at the overall incidence of stroke in the congenital heart disease population as a whole. This is all comers, not just the critical high-risk group, and they found an incidence of about 0.5% for all children undergoing surgery. And increasingly, we see stroke in children that are not surgery-related, or at least not apparently surgery-related, what I often refer to as the silent strokes. When you see these kids in clinic a number of years later and they have issues like seizures or headaches and you do scans on them, you often find incidence of stroke, which was not detected at the time of the stroke. The true incidence of this, though, has not really been looked at. Now, a number of studies have looked at postoperative strokes, and these are the first few studies here, ranging anywhere from the low of 3% based on clinical studies up to a high of about 20%. Most of the work and most of these names are coming from either the East Coast at CHOP or Boston, or from the West Coast, particularly UCSF. But Dan Licht, who's out at CHOP, and Brennan, who's out in San Francisco, what they showed was that preoperatively, this is prior to getting to surgery, there was a significant incidence of stroke in these children. And the reason for this big variation really came down to what was defined as stroke. As I'll show a little bit later, many of the injuries we see in the brains of these children are these very, very small white matter ischemic areas, as opposed to what we would typically regard as a traditional stroke. If all of those are included as stroke, then the incidence is actually fairly high. If one's looking at more territorial traditional stroke, the incidence runs closer to about 10%. And one of the few autopsy studies looking at children with congenital heart disease specifically focused on stroke came out of Loma Linda, where they looked at their children that had died following heart transplantation, and a full 1/3 of these children at autopsies had evidence of stroke in the brain. Now, seizures and epilepsy, again, I'm just going to touch on briefly because I want to highlight some of the importance of the recognition of the seizures as far as long-term neurodevelopmental disability. There's a ton of different etiologies for these seizures post-surgery, including infection, electrolyte balance disorders, and then cerebrovascular stroke incidents. However, the one seizure type that is fairly unique to this population is what's been referred to as post-pump or cryptogenic seizures. We don't entirely know the basis for it, but they are very, very stereotypical, and they follow a very, very characteristic course. The onset is typically within the first 24 to 48 hours. The onset is very abrupt, and the seizures are repetitive, and status epilepticus is really not that uncommon. The good news is that the seizures are really just confined to a short postoperative period, but they're often really, really difficult to treat or to stop the seizures. However, the prognosis overall is definitely better than the prognosis we typically see with global hypoxic ischemic injury. And this is an example of a young child that came back from surgery for a transposition, was sedated and paralyzed in the ICU, so there was really no window into the brain at all. There was nothing really to rely on. There was a little hemodynamic instability, but it's really hard to differentiate that from the underlying cardiac issues. And as is illustrated on the CEG, coming out of the left central region is this ongoing seizure here, which is essentially status epilepticus. And this kid had been in status epilepticus for quite some time, but was not recognized based on clinical criteria. So there's been a lot of work and a lot of studies looking at the incidence of seizures post-bypass. Clinically, only about 15% of seizures are detected, relying on the hemodynamic change or clinical movements. The first really big study looking at children with congenital heart disease was the Boston circulatory arrest study, where they compared circulatory arrest versus low-flow bypass. And the incidence of electrographic seizures in that study was 20%. But the importance was that those children that had electrographic seizures had an increased risk of having an abnormal brain MRI scan. And when you looked at the PDI on their Baileys at 1 year, it was lower, as well as their IQ at 4 years of age. A subsequent study from CHOP showed that the overall incidence of subclinical electrographic seizures was about 12% for all comers, although if you looked at the hypoplastic or the single ventricle group, it was closer to 22%, about 1 in 4 or 1 in 5. But this was the striking finding from that CHOP study, was that within that first 48 hours, the mean number of seizures was 72. So these are children that are essentially in status epilepticus and are typically going unrecognized because these are electrographic seizures. Now, what was interesting in this CHOP study was that when they did the Bailey score at 1 year of age, they did not show any difference between those children with and without seizures. This sort of highlights one of the limitations of the Bailey, especially early on, where really the emphasis of that Bailey is on motor development. When the same cohort of children were followed long-term by the CHOP group, what they did show is that by age 4, these children were starting to display deficits in executive function and social behavior, so that the presence of seizures, whether causative or whether just reflecting underlying damage, is still not known, but it is very clearly associated with prognostic outcome. And it can be refined a little bit further. In children on the right side of the screen here that undergo hypothermic circulatory arrest, if they either do not have circulatory arrest or the circulatory arrest is kept to less than 40 minutes, the incidence of seizures is really pretty low, less than 10%. Once the circ arrest time goes beyond 40 minutes, there's a significant increase in the incidence of seizures. This can also be looked at based on the heart lesion or the heart problem. Again, with single ventricle physiology or hypoplastic left heart, or even with significant complex two ventricular pathology, there's a fairly significant incidence of seizures in these children. Whereas in tetralogy, a little bit in transposition VSD, that incidence is far less. So I want to move on to the bulk of the talk, which is really talking about the neurodevelopmental disabilities. And the studies have been fairly unanimous and fairly strongly in agreement about the outcome measures and the metrics. Almost all of these studies have relied on the Bailey's developmental screen. And what it has shown is that if you look at the mental developmental index, the MDI, which is really a reflection of cognitive ability, if you compare it to the mean, which is in the solid black line at 100, there is a left shift. There is a slightly lower IQ, but it's less than 1 standard deviation from the mean. However, when you look at the psychomotor developmental index, or the PDI, again with a mean of 100, the average here is more than 2 standard deviations from the mean, telling us that cognition is relatively preserved, but psychomotor development is really what takes the hit. And there have been tons of studies confirming this. We know that about 30 to 50% of children are in remedial school services, but more importantly, about 15 of these children require full-time special educational help. About 20% do need some help in the classroom, and about 13% actually require additional help outside of the school. Also importantly, ADHD has emerged as a significant dysfunction in these children with congenital heart disease, with an incidence of around 30%. And if you compare that to the background population of children, neurotypical children with ADHD, the incidence is probably about 9%. So this is about a 3-fold, if not higher, increase in ADHD in these children. Now, this is the crux of about 2 decades of research and a ton of money that was spent trying to optimize cardio bypass surgery in order to reduce the neurologic morbidity. I'm just going to go through it really very quickly and not spend too much time on it. But what we see in this bar graph here is that this was the Boston Circulatory Arrest study, the PH study, the APOE, a Canadian study, and then a hematocrit study. But what we see is, despite these numerous studies with big numbers, big volumes, that in blue here, which is the MDI, really remained unchanged no matter what manipulation was done to the bypass surgery. And similarly, the PDI, which showed a significant reduction over these 2 decades, remained completely unchanged. So that no matter how much one optimized bypass, the end result really didn't budge. It was no different to going into these trials. The deep hypothermic, the Boston study, basically looked at circulatory arrest versus low-flow bypass. And very early on, the Boston group was claiming victory, suggesting that low-flow bypass had significantly better outcome than the deep hypothermic circulatory arrest studies. However, by 8 years, and with very little dropout of these patients and with good survival, it actually showed that there was really no difference based on the 2 groups, and that circulatory arrest, if done under the 40-minute mark, was really no worse or no better than doing low-flow bypass. They looked at pH strategy, like do you need to correct the pH based on the temperature of the child at the 18-20 degrees, or should you warm the blood and correct it? And really, again, it made no difference as far as neurodevelopmental outcome. The only thing it did seem to interestingly change was that a couple of decades ago, post-bypass, we used to see a significant number of children that had post-pump chorea. So they developed this choreiform movement after surgery in a very significant number. Following the change in pH stat management with bypass, that has all but disappeared, and I've probably only seen 1 or 2 cases in the last decade. And the third was the hematocrit. What is the optimal hematocrit to operate on these children? And they studied it everything from down to about 21 or 22% up to 30%. And it seems that around 30% seems to be optimal. However, the more important issue was that despite all these changes, there was really no change at all to the results of the Bailey's outcome of these children. So at the end of these 2 decades, what did we know? Well, we saw a particular developmental profile in these children. The first was that the intelligence, as I mentioned earlier, was relatively spared. It was less than or about a 0.5 of a standard deviation from the mean, but for the most part, these children cognitively were fine. However, we saw a very specific pattern of behavioral problems, visuospatial problems, and language difficulty. The behavioral problems were really to do with executive dysfunction, and I've already alluded to the ADHD incidence. There was also very specific visuospatial dysfunction that these children get. They get fine motor and motor dexterity dysfunctions. Apraxias are very, very common in these children. Depth perception is an issue. And then they also have a very specific, profile as far as language difficulties. They often have articulation issues. They have more of an expressive language problem than a receptive language problem, and they have trouble with phonological awareness. Now, what also became apparent was that you picked your poison. So children that underwent low-flow bypass tended to fit a little more with profile having behavioral difficulties, where those under circulatory arrest or significant circulatory arrest had more issues to do with visuospatial language and fine motor problems. But what was really striking at the end of this was that this developmental profile is really a very, very similar profile to what we see in children born prematurely, typically under about 34, 35 weeks gestation. And so at the end of these 2 decades, the question arose that since this is a similar disability to what's seen in prematurity, could PBL, or periventricular leukomalacia, be the basis for the neurodevelopmental disability? So we have a sagittal view here of a child born preterm with PBL, and you see on these T1 scans these little bright white signals in the white matter, which are the sort of classic hallmark of PBL, or periventricular leukomalacia. On the right side of the screen, the first 2 here, we see the same appearance on the sagittal, and this is on an axial view here, of these white matter lesions in a very similar distribution to what we see in the premature babies. And when you look at a diffusion map, you can see there's these defect in diffusion, suggesting that these are in fact ischemic in nature, typically like we see in premature babies. This was then supplemented by a really remarkable paper by Hannah Kinney in 2005. And Dr. Kinney is a wonderful pathologist at Boston Children's Hospital that has done amazing work in prematurity, but also in congenital heart disease. And what she showed in doing autopsies of children that had died from congenital heart disease, they were expecting to see more traditional stroke as the cause of the neurologic morbidity. But what they found was, in fact, that the damage to the cerebral white matter was really the most significant lesion, both with respect to severity and incidence. And she noted that this was very similar to what we see in the premature babies in the white matter. So at the end of the 2 decades, it was sort of back to the drawing board. It was a lot of frustration that all this money, all this work had been done, looking at these different ways to modify bypass, but yet at the end of the day, it really didn't impact or affect the neurologic outcome. So people started wondering, what is the potential mechanism that disrupts brain development and causes PBL in the fetus with cardiac dysgenesis? How is it similar to the premature baby, and why would it be that way, given these are completely different pathologies? And really 2 things began to emerge. The one was that there's obviously an intrinsic genetic susceptibility for some of these children with congenital heart disease. A number of children with congenital heart disease, and we'll talk about it in a minute, have an underlying genetic mutation and or a genetic syndrome. The second, though, was really starting to pay attention to and focus on the circulatory patterns in the fetus and how very different this is in children with congenital heart disease compared to that of a normal child. And due to this impairment in the circulatory support, there becomes problems with the delivery of nutrition, decreased blood flow to the brain, as well as decreased oxygen utilization. So I'm going to focus first on the genetic susceptibility, and then we'll talk a little bit more about the specific pattern of fetal circulation. So again, it's been estimated that about 20 to perhaps as much as 30% of children one can identify an underlying genetic or syndromic cause for their congenital heart disease. What's very interesting is that chromosomal abnormalities account for the vast majority of these, about 12 to 14% of all live births. However, it accounts for about 20 to 33% of all fetal cases, sort of implying that a number of these children either pass away in utero or are potentially aborted. And de novo mutations account for about 10% of the severe forms of congenital heart disease. And what's really becoming interesting is a lot of these de novo mutations affect histone methylation and the expression of genes. This was a nice study that came out just a few years ago, in 2018, and was a prospective study, but looking at prenatal chromosomal microarray, a CMA, in pregnant women with fetuses with congenital heart disease. If you go down to the very bottom line, it was a fairly big study of 600 patients, and about 20% of them had evidence of some genetic underlying abnormality. Again, the complex congenital heart disease had a very high incidence, as did conotruncal defect, as would be expected, and the AB septal defects, essentially trisomy 21, obviously had a very strong correlation with a chromosomal abnormality as well. But again, showing that there is this very, very high incidence of actual chromosomal abnormality with these disorders. But more recent work has shown that copy number variance is really also becoming important to start to look at. And pathogenic copy number variance is thought to occur in about 5 to 15% of children with congenital heart disease. It's been reported to about 14% with single ventricle defects, and that compares to about 4% of control subjects. And those that had these de novo suspected pathogenic mutations had worsening development as well as worsening somatic growth. And additionally, you see a higher number of these copy number variants in children where there are extra cardiac abnormalities. One of the more recent things that are emerging is particularly with the Wnt signal transduction pathway. And increasingly, we're starting to identify homeobox genes, other genes that are important in directional development in the fetus, and that a lot of these genes are involved both in heart directional development, but also have a role in brain directional development. So this relationship between the brain and the heart, when there's an abnormality of the one, seeing it in the other, is not that unexpected when you think about many of these types of genes that are now sort of impacting development. So if one looks at it, about a third of the patients roughly are going to have some underlying identified genetic mutation. The chromosomal analysis is a bigger group, but these de novo gene mutations are becoming important. The copy number variants, there's still some work to be done on that, but they are starting to become, again, an important area of exploration. This was a study done at CHOP when they looked at their incidence of hypoplastic left heart syndrome. What they found was that about 30% of these children had some form of developmental brain anomaly, but importantly, about 10% had a very significant overt brain anomaly. So this is a pathology specimen, obviously, of the hypoplastic left heart, just for people that haven't seen it, just showing how small the left ventricular chamber can be. And this brain anomaly is known as holoprosencephaly. This is the brain's equivalent of a single ventricle. Normally, your ventricles should be split. You should have an interhemispheric fissure coming down the middle here, and the brain very clearly cleaved into a left and right. And here you have essentially a single forebrain with a single ventricle. These are very, very significant malformations. So there are a number of very common syndromes associated with congenital heart disease, which is well known to people. The trisomies, the incidence of congenital heart disease displayed in the middle column. And then people are familiar with the 22q11 deletion, which outside of the trisomy 21 is probably the commonest associated cardiac defect we see, Williams syndrome, Kruder-Schacht, and others. But there's another way of looking at this. there are a number of just common syndromes that are also associated with congenital heart disease. Some of them we're very familiar with, and we always look for cardiac involvement when they occur, such as Marfan's, Kabuki's charge. The rasopathies are becoming an increasingly important group. Some of them are well known, like cardiac cutaneous fascia and the Costello syndrome. The arrow's just slipped a little here, but what I want you to point out amongst this group is neurofibromatosis type 1 or NF1. And many people don't realize that there's a fairly strong association between congenital heart disease and NF1, with an incidence estimated from about 10% to 20%, and often involving aortic coarctation as well. So any child with NF1 really should have a baseline cardiac screen. And then finally, there are a lot of single gene defects that can lead to heart disease, where it's primarily the heart that is the problem. And again, based on the type of mutations, genes have been now found or associated with it. So if you know the type of heart lesion, you can either do a targeted gene panel looking at that particular lesion, or when it's not immediately apparent, there are now these gene panels for complex congenital heart disease, and the pickup rate of that is actually increasing as more genes are added to that panel. So I want to spend the last part of this talk looking at the aberrant circulatory patterns as far as the fetus goes. So this is the normal circulation. We have oxygenated blood coming through the umbilical vein from the placenta. It goes through a selective channel in the liver, the ductus venosus, comes through the inferior vena cava, and obviously in utero, the child doesn't need blood to the lungs, so they have the PFO, the foramen ovale. Blood goes into your left ventricle, where the oxygen content's around 68%. It's then ejected through the aorta, a very decent-sized aorta, and there's antegrowth flow up to the brain. And then blood returns into the right side of the heart with a concentration of 53%. Now, if we compare that to children with hypoplastic left heart syndrome, there are two issues that occur here. So we do get oxygenated blood coming through, but because there's essentially no ventricle on the side, we have sort of a pooling or a mixing of blood. So the oxygen saturation in the ventricle that's going to get to the brain is significantly reduced. The second problem, though, is if you look at this ascending aorta, it is very, very small and very, very narrow, often down to about 1 or 2 millimeters in size. So very often, flow to the brain actually relies on retrograde blood flow. So as blood comes out of the right ventricle through the pulmonary artery, it goes through the PDA, the patent ductus arteriosus, and retrograde will go and fill the brain. So this model, you have two issues. There's decreased flow to the brain, and there's also decreased oxygen and glucose utilization. And if you've not seen it before, it's pretty striking. This is the ascending aorta, and this is the pulmonary artery, and the sizes should essentially be reversed. Now, with transposition of the great arteries, what happens? Well, we have the oxygenated blood coming into the heart. It goes into the left ventricle, so it's at the right concentration of oxygenation, and it's a very good, but the problem is, attached to your left ventricle is your pulmonary artery, so you're getting oxygenated blood going to the lungs where it's not needed. On the other hand, the returning hypoxemic, relatively hypoxemic blood is going out through a very nice sized aorta, normal sized aorta, through antegrade flow to the brain. So in this situation, the flow is normal, but there's a decrease in the oxygen and the glucose content. And here you have what is the relative comparison of a normal sized aorta to the pulmonary artery. The problem is it's attached here to the right ventricle and not to the left ventricle. Now, to understand the implications of that, we have to just talk very briefly about normal brain development. So work done by Petra Harvey, a wonderful neurologist and neuroradiologist who's now in Switzerland. What she showed is that as you see in the third trimester, from 28 weeks gestation right up until term, if you look at the surface area of brain, there's a linear relationship in the increase in size of the brain. And you can see this in the top illustration with very simplified gyral formation of the brain compared to the mature brain where there's a lot of gyral formation, which significantly increases the surface area of the brain. Remembering that the cortex, even in an adult, is only about 5 or 6 millimeters in size. So it's this gyration and folding of the brain that really gives it its large surface area. Now, work done by Andre Duplessis and Karen Papoulis out of Boston Children's Hospital showed that if you look at if you look at the normal brain development, this is what Petra Huffey had shown in the red here, that as the gestation increases, they looked at, instead of surface area, they looked at total brain volume. So they included things like the ventricular size with it. But it showed the same linear relationship. What was important, though, if you look at the children with congenital heart disease represented in blue here, that at the onset of the 3rd trimester, it started to diverge from the growth of the normal child, the normal fetus, excuse me. And so by term, there was a significant discrepancy in the volume of the brain of a controlled child versus a child with congenital heart disease, telling us that this brain is not growing as well as a controlled fetus. And again, a number of studies have confirmed this, but also shown that this lack of growth involves all areas of the brain. It involves the white matter of the brain, it involves the cortical plate, the neurons, it involves the subcortical or the deep gray structure as well. So the whole brain is affected in this growth impairment. And work again from a chart by Shillingworth showed that if you look at the normal Gaussian distribution of head circumference, children with particularly hypoplastic left heart have a left-shifted curve with a higher incidence of children at birth having microcephaly. But more importantly, what it relied on, what they showed, was it was dependent on the size of the ascending aorta. When the ascending aorta was essentially less than 3 millimeters in size, the children ended up being microcephalic. Those children where the ascending aorta was 3 or more millimeters in size, they ended up with a normal head size. And they showed this by comparing it to the transverse aorta, where there was really no size difference, and there was no difference between microcephalic and non-microcephalic children. Again, confirming the earlier impressions and studies that it's the flow to the brain that was affecting the brain development. And perhaps the nicest piece of work coming out of this era was work done by Dan Nechter at CHOP. This is a slightly complicated slide, but it's very important to understand. What they looked at was what's called TMS, or the Total Maturation Score. And the Total Maturation Score looked at surface area, it looked at blood volume, it looked at brain differentiation, it looked at ventricular size, it looked at about 10 or 15 different markers of brain growth, and they gave it a score. What we see in the most left part of the graph here is that the total maturation score for a child born at term, a normal child at 38 to 43 weeks, the maturation score was about 12. If you see a child born just slightly premature at 36 to 37 weeks, it drops down to about 11. Now, here's the kicker. If you look at children with congenital heart disease, we know that on average they are born at term. In fact, the mean gestational age is around 39 weeks for children with congenital heart disease, so essentially at term. So they really should have a much more significant total maturation score, but instead their mean is around 10. And this is a very significant difference in the maturational score. And if you trace this line back to at what point in brain development is the maturation score 10, it turns out that it corresponds to about 35 weeks gestation. So why is this important? Well, it's telling us that these babies that are essentially these congenital heart babies that are being born at term, but yet the brain, the maturation of the brain, is closer to that of a 35-week, in other words, a premature baby. So this gave us the first insights as to why we maybe are seeing these injuries that we see in a premature baby. And just to show how significant this is the normal brain development with gyral formation. This is what a normal term brain looks like. This is what a congenital heart child's brain looks like. And it looks much, much more similar to a 34-week gestation than it does to a term gestation. Again, reinforcing that despite the chronologically being born at term, their brain development is significantly delayed. So why is that important? Well, we know from premature work, studies on premature babies, that prior to about 34 weeks, there's a significant population of what's known as oligodendrocyte precursor cells. The oligodendrocyte is the cell that is going to form the myelin for the brain, that's going to surround that axon, form the myelin for the brain, and allow for signal transduction. The oligodendrocyte is exquisitely sensitive to hypoxemia, and this is the key element. This is why premature babies have the problems they have. Once the precursor oligodendrocyte matures and becomes a mature oligodendrocyte, it is very, very resistant to hypoxic injury. And in fact, why at term you see very few precursor oligodendrocytes left, they're now all mature oligodendrocytes. So mature babies, for example, that have HIE, or older children that have problems with hypoxia or ischemia, they end up getting cortical damage, gray matter damage, what's known as selective neuronal necrosis. There's certain vulnerable neurons in the brain that now become susceptible to hypoxemia. But before 34 to 35 weeks, it's these pre-oligodendrocytes that really predominate, and they are exquisitely sensitive to hypoxemia. And the last line of evidence of fetal brain problem came through using MR spectroscopy. And as imaging is advanced, we're getting better and better information. This was Karen Lipopoulos, this was Steve Miller's study, but both showing essentially the same thing, that in these fetuses with congenital heart disease, and this was in particular the hyperplastic left heart children, a little bit less in the transposition kids, there were significant lactate peaks building up in the brain, telling us that these brains are being starved of oxygen. And so the brains were accumulating lactic acid. So if we look at the fetal causes of neurodevelopmental disabilities or disposition towards it, there's a failure of bone growth, as I showed you, starting at the onset of the third trimester, that you start to see this divergent pathway. And the third trimester is really what's responsible for rapid brain growth. It's particularly impaired, this growth, in children that have decreased aortic arch flow, in other words, narrow ascending aortas, and also in those children that have significantly reduced oxygen glucose content. And more particularly, this hypoxic scenario is acting on these vulnerable pre-oligodendrocytes, which really predispose to white matter injury. Now the baby's born, and before they get to surgery, again, an area that wasn't fully appreciated, we thought once the baby was out of the uterus and you could stabilize the baby, they would do fine. The problem is there's sort of significant ongoing concerns prior to them getting to surgery. Ultrasounds have shown anywhere from 40 to 60% abnormality. I'm really not going to talk about that because most of the descriptions of the abnormalities are relatively irrelevant and minor. It's not really very helpful. However, if you look at preoperative MRI, anywhere from 25 to 40% show developmental brain anomalies in these children, not picked up by cranial ultrasound. More importantly, preoperative, before getting to surgery, MR spectroscopy shows more than 50% of these children have elevated lactic acid content in the brain. And this was work by Steve Ashwell at Loma Linda and Steve Miller out in the West Coast. And using DTI imaging, again, abnormal white matter development was seen in a number of these children. Again, this was a study just came out a few years ago, but what it showed was that newborns that either had uncorrected cyanotic or single ventricle physiology had impaired perfusion of the brain. Here we have it centered on the basal ganglia. We're looking at arterial spin labeling, in other words, perfusion of the brain, how much blood is getting into the brain. And what they showed was that not only was there a global reduction compared to controls in blood flow to the brain, but there was also some specific regional blood flow, particularly in the basal ganglia. If we look at abnormal MRI scans before getting to surgery, again, the overall incidence, if you drop down right to the bottom here, was that on fetal MRI, the incidence was about 16%, and that on the preoperative but postnatal MRIs, it was double that, it was 32%. And only 9 of these children actually had an abnormality on the prenatal scan. So a lot of this was being done in the newborn period. The highest issue was seen in children with the fetal stuff in the transposition children, and postoperatively, preoperatively, but postnatally, it was the children again with the hypoplastic left hearts and the TGAs. And this is a study out of Germany, again showing that preoperative venous oxygenation was significantly related to IQ in these KID2 scores, and that the postoperative central venous oxygen saturation really didn't have any correlation with the outcome. It was all this preoperative period where this damage seemed to be done. And finally, there was also a lot of neurologic evidence based on examination and special studies showing that there was evidence of damage to the newborn before they got to surgery. About a third of them had microcephaly, about 50% had abnormal neurologic examinations, and more importantly, EEG abnormalities were seen in about a quarter. More importantly, outcomes at 1 to 5 years were very closely related to these preoperative neurological findings in these children. And I'm going to end with some really exciting work that has come out in the last year or two, trying to understand why. We now know neuroanatomically what is occurring and why it's occurring, but we still don't know exactly why it gives rise to the kinds of problems we're seeing. So this is work that's been done both within the premature babies, but also in the congenital heart disease population. And what we now realize is that although we usually think about brain development as being complete at the end of the second trimester and brain growth occurring thereafter, there's a significant number of these neural stem cells or these progenitor cells that postnatally, after birth, are going to migrate into the frontal lobe of children. And the cells, these cells are in the area of what's known as the subventricular zone. And these cells migrate into the frontal cortex, but they're very important for becoming what are known as interneurons. So we all know migration, you get the neuron going out to the surface, and then you have the axon, which is carrying the signal that comes down through the center of the brain, through the white matter brain stem, and down into the spinal cord. However, there are also interneurons. These are connections between the neurons. So instead of being vertical descent, these are horizontal sort of connections between the neurons. And these interneurons are very, very important for inhibitory factors. And so an absence of these neurons or damage to these neurons results in a frontal cortex that has less inhibition, more problems with executive dysfunction. And I'll just show you what this, on the side here we see a view of the brain that is a sagittal view with the patient to the side here. This is known as a coronal view, which is where if you were to just look down, if you were to look directly into the eyes of the child. This is the lateral, the ventricle on the left here, the left ventricle. This is the subventricular zone here. These are these interneurons that are going to migrate. They go out through two pathways. There's a medial migratory stream that goes into the forebrain, and there's also a rostral migratory stream. But this is the area where PBL hits. It's right in around these frontal horns where the subplate neurons are likely to start to migrate to the surface. And this is starting to give us some idea now why these children have a lot of the executive dysfunction that they have. There's still a lot of work to be done with this, but it's very, very interesting early and preliminary work. So our understanding these days of the insult to the brain has really, really changed dramatically. Whereas before we really felt that surgery and post-surgery was really the mainstay of damage to these children for all these various reasons, we actually now realize that as important, if not perhaps more important, are antenatal factors, which we refer to the genetic syndromes, the altered in utero blood flow to the brain and oxygen delivery, as well as problems in the neonatal but preoperative period. And that evidence of PBL and stroke already exists before these children get onto bypass. So the surgeons, while perhaps not totally blameless, are really not responsible for a lot of the long-term neurodisability that we see. And so it's moved into the next era. We realize that perioperative neuroprotection is really not there. If we really want to make a difference, how do we get to fetal intervention? And this is starting to occur, particularly with critical aortic stenosis or outflow obstruction, where, again, trocar catheter can be introduced and they can do balloon dilatations of the aortic valve. However, for a lot like the hypoplastic left heart syndrome, as I mentioned, the problem really starts at the onset of that third trimester, where you start to see the brain starting to suffer. And the question is, how do you get to that to improve circulation and to improve oxygenation? So I'll end with a couple of just key takeaways. That, again, just to emphasize that neurological morbidity remains the major extracardiac manifestation for these children with congenital heart disease. Survival is really no longer a concern or a problem. The neurodevelopmental disabilities is very, very common, 30, perhaps up to as high as 50%, and that these prenatal and preoperative factors may be as important, or if not more important, than the perioperative or the postoperative factors, and that genetic vulnerabilities is also very key. And finally, this is acting in an area in the fetus where you have this population of brain cells that are very predisposed towards hypoxia ischemia, leading to PBL, which seems to be the basis, like it is in prematurity, for the neurodevelopmental disabilities. And again, I haven't focused this talk on, but stroke and seizures are also very significant and important complications in the early phase of children with congenital heart disease and surgery. So I'm going to end there with 5 minutes, and I would certainly be happy to take any questions.
Thank you, Dr. Friedman. Wonderful presentation. We do have, as you said, a few minutes here for questions. Let me start us off with one of your earlier slides showing mean IQs and other metrics, neurodevelopmental metrics post-surgery. It wasn't clear to me if those averages were taking into account kids that did have known syndromes, whether it's trisomy 21 or other types of syndromes, or was that, for those kids, excluded in those studies?
Well, so those original studies were actually, again, most of this work has more commonly come out of studying the children with hypoplastic left heart syndrome and those with transposition of the great arteries, because of the different physiologies, they've served as a sort of basis for the studies. So it does exclude children with trisomy 21s or any of the obvious underlying genetic syndromes. So yes, if you looked at, I didn't talk much about it, but if there is evidence of an underlying genetic syndrome, not only is obviously the IQ affected, but often these children are born slightly smaller, like an IGR picture. They often will have microcephaly as components, but they seem to be sort of a different category. But yes, the IQ in the studies that I'm alluding to were the studies that have been done looking and comparing TGA and hypoplastic left heart syndrome in particular. Even common things like tetralogies, etc. The data on that is not as well studied as it is in those other two groups.
Thank you. Any other questions for Dr. Friedman? Well, Dr. Friedman, thank you again. Really enjoyed the presentation and appreciate your time preparing this morning.
My pleasure. Thank you for asking me.
Well, everybody have a great day. Bye-bye.